Thank you very much, President Monaco and Dr. Harris and Professor Gobak for your kind talks, and Eileen as well. Thank you very much. We'll now move on to the afternoon session, and we should be ready to go, and I am actually the first speaker, so I will just continue from right here. So what I'm going to talk about is a clinical trial that we've done in Kenya. And pretty much we were asking the question, does food supplementation matter in early HIV? And the issue is food insecurity is a major problem globally. We produce much more than we need, but unfortunately almost 1 billion people are chronically undernourished. And food security is also a recognized problem in HIV and is a driver for the HIV epidemic internationally. Multiple countries, multiple continents. And when we looked at the studies that have looked at HIV progression, we found that most studies that looked at the distal end of the epidemic, when patients were really sick, when they were wasting, and that's when most of the work had been done. And very little had been done earlier on in the disease to find out whether or not it makes a difference, and what are the circumstances under which that might make a difference. So we've worked in, this study was in Kenya, in the southeast region, which is about 200 miles from Nairobi. And the whole county is about 300,000 people, and the major centers have populations of about between 30 and 60,000 people who live there. And of course, during the day, there's migration up and down depending on commercial needs and demands. And so when you zoom in, you find that that's the main highway from Mombasa to Nairobi, that's the Indian Ocean, and Voi, Undanyi, Motate are the different sites that we worked in. And when you look at food insecurity in this region, based on our own research that we've done there, we found 67% both amongst HIV positive and HIV negative are food insecure, and 30% are actually severely food insecure. So we already have a problem with food security there. Unemployment, 40% nationally and 70% in this region. Household income is median of 4,000 shillings. That comes to about, with a household of 4 persons per household, 42 cents per person per day. And we also looked at how the spending patterns, what are the demands in the household? We found 85% spend less than 500 shillings a month on healthcare. So that is about $7 for the whole household. And 80% will spend more than 1,000 shillings per month on food. 52% spend more than 2,000 shillings on food. So you can see already there's competing interests within the households, and we were able to demonstrate that, and that also gave us some insight into what's going on over and above food. This is what the area looks like. That's Voi Town, one of the main streets. Very dry. Rainfall has been MIA since maybe 5 to 6 years in the last decade. So agricultural production has been very low, which doesn't help in terms of food security. So we thought about this because food insecurity is multifaceted. It's not just about they lacked food, they didn't get the nutrition. There's so many other aspects to it, and that actually may influence overall health, and therefore food supplementation could do something more than just nutritional value. And the other socio-economic aspect of food insecurity is that it's influenced and influences other needs within the household that are competing, and that might need health needs, education needs, job-seeking efforts, creating a vicious cycle. So one makes the other worse, and it in turn makes itself worse. And we know from FAO and other sources that food production in sub-Saharan Africa has been very low. So thinking about this, the conceptual model that we have here is the socioeconomic status, which influences and influenced a lot by job insecurity, has multiple impacts in that household or individual's life. And one is it affects access to food, which also affects how much food security there is, and that in turn can affect nutrition intake, which would help affect nutritional status and may affect HIV disease. On the plane of health-seeking behavior, you have access to healthcare will be affected if you don't have money to or the places where you live are far from healthcare. That affects healthcare behavior, and that can affect adherence. Even if you get medical care, the adherence to care might not be optimal, and that again can affect overall health status and nutritional status. On the other side, income is little. We have a lot of unemployment. That affects ability to pay for healthcare-related costs, plus many other costs within the household, and that would also affect how treatment is obtained or paid. So you might find patients who come in, they're seen by the doctor, they're given a script to go collect their medicines, and they head straight for the main gate and they're gone because they can't afford what they have to pay for the medications. So all these things, just because somebody did sick behavior doesn't mean automatically that they get it, because there's so many other issues that are happening. And one thing that we know of but do not pay too much attention is how these are all linked, because within one household, how much money there is, whether or not they need to get care, and how much food there is are all linked in all these multiple levels. And so this is an important aspect of how and why we were doing what we were doing, as opposed to just looking at the axis of food and how that affects HIV status. So we had a study, this was funded by NIH, and we worked with the Taita Taveta County Ministry of Health. Some of my collaborators here were Chris Wanke, among many others, and because not much work had been done in rural sub-Saharan Africa on nutrition to the level in which we wanted, there wasn't much data to compare to. We thought it would be a good idea to have what's the normal, or what's the non-HIV population. We're glad we did this, because we could have blamed so many things on HIV just to realize that the HIV group is also just as food insecure and has quite a number of the same issues as the HIV positive population. So the main objectives was to determine food security, nutrition intake, nutrition status, as well as socioeconomic status in the local population, both for the HIV positive and negative, and then to evaluate the effect of food supplementation in early HIV disease that was defined by CD4 counts greater than 400, to how fast they would need to start HIV and how the CD4 decline would be. And this, I'd like to tell you, is actually the first time we're presenting this data, which it's just right of data analysis for the very first time. So we've not even gone very far into the depths of the analysis. So this was Taita Taveta County. We looked at the HIV positive women plus the negative controls. We had adults 18 years and older. It was a randomized controlled trial. It was unblinded because some were getting food and the others were not. And we were comparing what we called a nutrition-dense protein supplement to standard of care. So these are healthy individuals. They have got HIV, they're infected by HIV, but typically they're healthy. So the food contained corn, soybeans, peanuts, dry milk powder, sugar, and dried omena. We went through a lot of processes to actually find out what proportions we need. We had this goal of it having extra protein, or 20% extra protein daily intake, and it would be ground into dry flour that would be a breakfast porridge. And to not overwhelm the people who would be taking it, we didn't want them to take it every day, so we packaged it so that if they took it for 4 days, that was equivalent of having all 7 days, so that they could have some days that they didn't need to take it. We did a test and focus group discussions to make sure that it would be acceptable. The test was good. The fish wasn't too much. The omena is like anchovies, the tiny dried fish that were ground into the flour. And we knew if we just give the patient the food, they are likely to share it. So we told them, this is your share, and you have an extra share for the rest of the family to make sure that they got what they needed to take. And we closely monitored the adherence of the intake. Amongst other things that we measured, socioeconomic status and demographic data. We looked at food insecurity using the Fanta's household food insecurity access scale. We measured depression using the CSD score. We took 24-hour recalls for dietary intake to assess macro and micronutrient intake. We did a lot of anthropometric measures, the 4 circumferences, the skin fold thicknesses, to make sure we could characterize nutrition status very well. And then we did the intention to treat analysis. So to give you a sense, the people we enrolled, actually this is 1991, sorry about that. But the mean age was 36. Education, not very high. Secondary school or higher was about a quarter. Household income was very low. Employment, very low. These ones in farm business are mostly they're on farm, and businesses would be hustling, buying and selling goods. Incidentally, even from our other studies, what we found that the people who own homes are the ones who are more food insecure. They live on median 30 minutes away from where they get their medical care, and it costs them about 50 shillings, which is about 70 cents to get to the clinic, but up to 500 shillings for some people. And in this particular group, the food secure group was only about 30%. Everybody else was food insecure, and about 24% were non-insecure, or severely insecure. Most of these were new diagnoses, the early disease, so median time was about a year and a half. And depression was just under 20%. BMI is 25, so these are healthy individuals. And CD4 count was 570, and viral load was 700, ranging to up to 3,000. So they're healthy individuals when we saw them, and then we gave them the flour. Every 2 weeks we delivered the flour, and we made adherence assessments every 2 weeks and saw them every 3 weeks for a total of 2 years. And this is what we saw at the end. People who ended up with the CD4 count less than 350, that is the cutoff for starting HIV treatment, or started ART before that for clinical purposes like opportunistic infections, 29% from the NDPS group and 49% from the standard of care group. And that is a relative risk of 1.71 with a p-value of 0.06. So we're still doing analysis to try and understand the mechanism of this, but it's exciting to see that difference, and we're really trying to understand what's going on. And if you look at those reaching the outcome, there's a big difference between the standard of care group and the NDPS group. So the thinking is, this is a big problem. Food security is a big problem in the household. These are also other major issues, and we believe, in addition to the nutritional value of adding the food, relieving that also gives some relief in this other side in terms of how they access care and how they can take more time to look for jobs and try and make their financial status slightly better. And this is a phenomenon that has also been seen in education, where school lunches are given to kids and the educational outputs is much, much better. I think there's some dynamic in the household that's happening, and that somehow improves this. So we're still yet to do analysis to try and see if we can get data that supports this theory. So we're still going to do our macro and micronutrient intake to understand some of those things, look closely at the adherence patterns and whether or not it was adherent. Look at longitudinal dietary patterns. Did they change by being given the food? Did it displace, or did it just add on? Relationship to depression, food security patterns, and changes in viral load, and hopefully even look at what baseline resistance there may have been as the primary infection. And most importantly, we'd like to do a cost-effectiveness analysis. Thank you.